will start the treatment. Do you understand? This kind of conversation must be there from the beginning to the end. Why to the end? Because the filter is so flexible, right and left side. So you have to do the same midline assessment at all times. Every time the patient comes, it's very tricky. Alright? Do you get it? Alright, now I emphasize the midline-based diagnosis. Midline-based diagnosis. So, and this will give you some kind of impression, or it can be some kind of clue. Oh my God, talking about the midline, Dr. Lee is never ever going to talk about clear alignment, because I was so much interested in Invisalign. No, I don't really hate Invisalign, but from a biomechanical standpoint, what does it do? What is the clinical implication of a midline-based diagnosis? We understand human body is always asymmetric, even by 1 millimeter. Always asymmetric. Is that correct? Always asymmetric. So, if you find a small discrepancy between right and left side in terms of an arch length discrepancy, you will try. Okay, now I noticed you have, you have 2 millimeter on the right, class 2 molar on the right, slightly less class 2 or class 1 molar on the left. We have so many of these cases. Always asymmetric. But do we try asymmetric mechanics between right and left side? Yes or no? But the price is 0149 time, 0169 time the next month. Does it lead us to have symmetric molar relation after all?
No.
Yes or no?
No.
No.
Yeah.
So, what does it mean? Midline-based diagnosis, what does it really mean? We need to be able to try asymmetric amount of tooth movement between right and left side. Okay? So what does it mean? If you think about the clear aligner is always reciprocal movement. You push something and you're pushed back. So midline correction is the weakness of the clear line at all times. Have this in your mind and go outside and go attend another Invisalign seminar in any part of the world, and you'll understand midline correction is always a problem. Don't try. Do you think you can be there too, or is it more comfortable to stay in the back room? No problem. Oh, really? Oh. All right. Now, real clinical practice. There are anatomic landmarks. Canthus line, nose ridge line, like I told you. Philtrum line is probably the most reliable. Philtrum is close to denture. And we have to focus on the soft tissue midline. Connect, like in here, connect the glabella, nose tip, and philtrum, and menton, soft tissue menton. This is the soft tissue midline. And you know menton is not always on the midline. They are off. So basically, you will use a philtrum as a main landmark for the soft tissue midline. It is the best to match the soft tissue midline with your upper denture midline. Of course, your upper denture midline must be coincident with the lower denture midline at all times, right? So what is important? Is your upper denture midline. That must be coincident with the soft tissue midline. Is that correct? Here's an example. Very simple case. 29, lady, mild crown. Okay? What are you going to do? You put the braces, align, start alignment. Is that correct? I don't think so. Okay, what about the midline? You like it? Yes, I like it. Exactly on the same line. But how come there's an asymmetric crowding between right and left side? You need to get this figured out. Is that correct? You need to get this figured out. Think about clear aligner. Think about clear aligner. You start insertion aligner from the number 1, 2, 3, 4. It will level and align the whole arch. So one thing I found in many of the aligner seminars out there, they don't seem to show the cephalogram. They just show the alignment, only the occlusal view. They don't seem to show the midline. They don't seem to show the upper and lower midline. They don't seem to show the cephalometric superimposition. So it is hard or almost impossible to figure whether it's a molar distalization or incisor flaring. Okay, Dr. Lee, let's not be sophisticated. Whether it's a molar distalization or incisor flaring, as long as it's aligned, it's beautiful, isn't it? It's not beautiful, at least in Korea. Korean patients are really demanding. Hey, Dr. Lee, I saw my face in the mirror. My lips are different from that 6 months ago. I couldn't close my lips comfortably. They produce tens of hundreds of complaints every morning, every night. How about your country? Where are you from? Romania. I see many people are very tolerable. Okay. Very good, very good. But I guess it will be hard for you to survive in Korea. Not easy. They notice 1 millimeter flaring. 1 millimeter flaring. If you don't get it, try to treat a piece of wax as a base plate wax that is whose thickness is around 1 millimeter. Put that on the surface of your central incisor. Long piece. That will increase the volume of your central anterior part by 1 millimeter. That will lift your lips by 1 millimeter. And try to feel whether that is noticeable, yes or no. That is very noticeable, very annoying. So that is identical with 1 millimeter flaring of the upper incisor. People notice it. They're not psychopathic. People notice that. So 1 millimeter movement, especially to the front, is very well noticed by most of our patients. I am not being very sophisticated, to be honest. I experienced those things many times. So I have to care about this thing. If you just put the braces, if you use a clear aligner from the first place, you will end up with a tiny little amount of flaring, yes, increasing the overjet, and more importantly, she had 3 incisors. Oh my God, I'm not supposed to create one whole big space for lower incisor. That's too much. So we have to compromise. Okay? This is a very, very commonplace case. You can easily see in your clinic, but even this is very problematic. You understand?
Yes.
Especially she's missing 1 lower incisor. So where should we start? She has a little bit excessive overjet. Just because she was a lingual case, we can try setup. Beautiful. Okay, beautiful. So does it give us any useful information? Yes or no? Yes? What is the information you get out of this? Huh? We can make the teeth in this way. That's a useful information. What tooth has to be moved, what direction, to what magnitude, amount? That is the useful information we should get out of this. Do you get some information like that? So at least one thing, okay, even if it was a free incisor case, we can compromise the midline in this way. It looks decent, looks nice. Looks nice, but the most important thing is how much movement at each side do you need to get? How much movement to make a conversion from class 2 to class 1. Okay, this was a simple case. You need asymmetric amount of distalization. Even if you compromise the ventral midline between top and bottom, you still need asymmetric amount of movement between right and left side. So my question is, putting the braces and inserting 014-016 night tie would resolve the problem? Yes or no? No. Clear aligner, is it going to resolve the problem? Yes or no? No. Right? So what do? Preliminary segmental distalization. Preliminary segmental distalization using what? Mini screw. Interreticular mini screw. How many mini screws did I use? 1 on the right, 2 on the left. Maybe because I needed more distalization on the left side compared to the right side. We're going to learn something like this. Hey, Dr. Lee, this is against the rule because she was lingual case, but you use labial attachment. That's okay. It doesn't show on the side, right?
Yeah.
Doesn't show on the side, so we can still distalize the molar that way. Even from a single photograph, you may raise hundreds of questions. Hey, Dr. Lee, I saw a lot of molar distalizer, this and that system in European countries. The guy was using mid-paltal mini screws assembled in this and that way, and distalizing force was given some complicated design. We use only interreticular mini screw because it's simple. Yes, it's simple. Is there another reason? I can explain exactly the reason why this is superior than using complicated devices. Maybe tomorrow in the afternoon. Obviously, there's a good reason for this. Very good reason for this. Okay. Today is the beginning. We started distalization. There's a little bit of tipping, but there's a jiggling type of tooth movement. Back and forth. We created a space up in the front. Now we are able to align. This is a sequence of the treatment. Okay? Sequence of the treatment. First, create the space, then alignment. Always. That's way better. Because this is what we call round tripping. Now let's get back to the first appointment. Just because you didn't listen to my lecture, let's say you put the braces on, you started 11 alignment 014-016. Okay. Now the molar relation is same. Just because there was a crowding, you must have created some flaring up in the front. Oh my God, I don't like it. And there's a midline deviation, iatrogenic midline deviation, and the patient starts to complain. Now you will see, okay, let's take a cephalogram and have a superimposition. And you notice that there was a flaring, okay? Oh my God, just because I don't think I will try extraction of the premolar at this time point. I'll have to think about molar distalization. Okay, we can try molar distalization at that time point when you notice there was a flaring. But think about the amount of task. What do you have to do? This way, your task was segmental distalization followed by alignment. Now, in the second case scenario, now you have to move all the things at the same time. Molar, second molar, first molar, second premolar, first premolar, and also then all 6 anterior segments must be pulled backward. Which one is easier? Which one is this? This is what we call round tripping. I was supposed to move from here to here. Okay, this is one step. Simple. If I walk around just like this, it takes time. It takes time. In the middle of this kind of movement, you lose your leg. What is that? Root resorption.
Yeah, root resorption.
Root resorption. You lose your surrounding. What is that? Available. No good. No good at all. The tooth movement has to be simple, straightforward, and shortest. Shortest. You have to understand, all orthodontists in the world must feel guilty. I'm sorry. I'm very sorry. All orthodontists in the world, without exception, must feel very guilty because we lose the root, we lose the alveolar bone, we lose the enamel, we create decalcification, but on the other hand, we must produce something with the least amount of sacrifice, least amount of damage, least amount of injury, and we have to get something out of it. So, try to make the route, try to make the itinerary as simple as possible, as short as possible. Do you get it? No round tripping at all. No round tripping at all. And just because according to the model setup, we ground upper incisors just a little bit, tiny little amount of stripping. So we were able to get some the clinical outcome according to the model setup exactly in the same way. Midline, you like the midline? Was it maintained? Yes or no? Yes. Profile, maintained. How is it maintained? Because we didn't flare the upper incisor. Okay? We didn't flare the upper incisor. This is important. Now, what did we learn so far? You have a dental arch. You pinpoint one point. What is that? Especially the upper dental midline. Based on that, you will decide amount of crowding respectively in either right and left side. So your extraction plan, even your extraction plan may be different between right and left side. It can be extraction on the first premolar, non-extraction, decellization on the other side. We do that. I do that so many times in order to minimize the number of extraction cases. Instead of a 4 extraction, 4 premolars extraction, 2 premolars extraction, 1 premolar extraction would be definitely better for the patient, isn't it? Right? So many times you do this kind of asymmetric molar decellization. It's very possible. So try to assess the midline at 4 times without exception, whether it's a grower, non-grower, surgical. And day after tomorrow, I will explain the way how you assess midline in surgical cases. Alright? In surgical cases. That's important. What do you think about the midline? Is it deviated or not? No? If you say no, you are very well advanced. Very well advanced. What do you think? Midline deviation, yes or no? Yes, but no. Yes, but no. Yes, but no. Yes, but no. It is yes, but no. Why? Exactly. Now she knows. Exactly. I'm going to make it simple. She has midline deviation. Yes. How much? About 2.5 millimeters. Are you concerned? Of course, 2.5 millimeters is a lot. So, do we have to think about very special plan for that? Something like asymmetric extraction or asymmetric decellization or something like that? Let's see. Anyway, midline deviation, but low incisor has been tilted. Tilting is very different from bodily movement. Very very different. So this was also again lingual case. Lingual case is very tough, very hard, but like I told you, I will show you the easiest and simplest lingual techniques at the end of the course. Anyway, we leveled. Of course, the leveling is not perfect yet, but somehow midline is matched. Coincidence between top and bottom. We didn't do anything.
Yeah.
We just pulled out the premolar and did the leveling and alignment. How is it possible? How is it possible? Upright. Okay, it's upright. Upright. But how come uprighting is so easy compared to the bodily movement? You just say it's by your intuition, right? Maybe rotating is easier. Huh?
It's rotating around the root, around the point.
So more specifically,
less bone remodeling.
exactly. So he's got a very good understanding. Less bone remodeling. Rotation takes much less amount of bone remodeling. That's the reason. One reason. Another reason, without your knowledge, there's one more thing. Actually, you told me you're not supposed to put 014, 012 night time without thinking about anything. That's bad. But we did the same thing here. We didn't give a lot of thought in the geometry and things like that. We could put the braces, even if it's a lingual case. We did it, and we aligned. Then we made it. How come? Incisors, the wire is engaged in this way, and this wire will create couple. Any couple. So I'm going to show you the whole case scenario next Friday. You finish it in this way, and the point is, if you give a couple, any couple that's given to an object will produce rotation around the center of resistance. Even if the couple is given on the crown, even if the couple is given on the root, or somewhere else, on the side, in the back, as long as it's coupled, it produces rotation around the center of resistance. Do you get it?
Yeah.
Okay? Maybe hard. You say yes, but in a clinical practice, you don't seem to get it many times. Just because they were killed as soon as you engage the wire. This is exactly why, if you go through the literature, the Damon people, please do not record my voice because I'm going to reveal very confidential parts that the company would not like to hear. I'm kidding. Sometimes the literature shows you a very beautifully aligned case without any special consideration on the geometry, and just put the braces, put the Damon, and use a Damon wire, and at the end, perfectly aligned without any flaring. I'm going to talk about this in about an hour and a half, the bracket geometry, alright? I will reveal the magic, the secret behind the magic, alright? Anyway, now, we are here to where we assess the midline. This is a midline deviation by tilting. As soon as you engage arbitrary arch wire, the arbitrary arch wire will produce a couple given on the center incisor will rotate around the center of resistance. Where is the center of resistance? And now you imagine the rotation around the center of resistance. Okay, the midline correction is done without any special consideration. Very good. Let's think about something else. I couldn't rescue her canine because I was pulled out at some local clinic without my knowledge was done. she's missing the canine. If she had visited me, I would have been able to save the canine, but we lost the chance. She lost the chance. So this is it. Some midline deviation, crowding. And you will try leveling and alignment. You will easily try intermaxillary elastics to correct the midline and also to correct the molar relationship. Okay? Now, one thing we have to consider is the patient's compliance. If you use something, this is a very simple case. If you use something like this, you must rely on patient's compliance. If she doesn't wear it, you know, if she doesn't wear it, you can still end up with this. Do you like it? Maybe yes, but your occlusion on the left side is not perfect. Not really perfect. Because of what? Because of lack of compliance. You can blame the patient, but I don't feel very comfortable about the result.
Yeah.
And she was supposed to wait for the next couple of years for the implant work, and something happened. Relax again, back to the canine position. Now the second chance has come. We have second chance. Okay, we'll do the midline correction one more time. Are we going to use the same technique using the intermaxillary elastics?
No.
She doesn't seem to collaborate. And also there's a occlusal plane canting.
Yeah.
Okay, so we need to create a couple millimeter more space on the left side canine from here. We use, okay, this is very well known technique. We use a mini screw and try visualization on one side. What you have to think about is not only the AP movement, you'll have to think about the three-dimensional movement. Try to think about the bathtub over here. This is a very good example. Very well done example. Because using a single force, you are able to not only create the space, but also correct the occlusal plane canting, alright? Now, the mini screw can be effectively applied in this kind of case. If the case is the other way around, let's say you have midline deviation together with the occlusal plane canting the other way around, then mini screw use is contraindicated, or it will take you much more time.
Yeah.
Sometimes, if your patient has an asymmetry, underlying asymmetry, you still have to do that, even if you know there is a occlusal plane canting in an unfavorable way. You still have to do it, but you know it takes much more time. Why? Because it takes much more amount of a bone remodeling. Root to movement is totally different from keeping. Now, maybe tomorrow morning we'll discuss more about that. Okay, so this way we were able to correct not only the midline but also occlusal plane canting. Why? Can you see that?
Yeah.
And also, what about the occlusion on the left side? It's better than the initial, because we didn't have to rely on the intermaxillary elastics. So, my advice is to try to use compliance-free technique or mechanic at all times, as long as possible, to increase your clinical success. Compliance-free orthodontic treatment. Okay? So this is the thing. Do not stick to the anteroposterior correction only. Do not stick to to do anterior-posterior correction. It's always vertical problem involved in here. All right? Always vertical problem involved in here. Like in this case, if it's a midline deviation and occlusal plane tinting in this way combined in the same case, a single force would correct the two problems at the same time. It is like killing two birds with one stone. Very good, very good. What do you think? Is this easy or difficult? Simple or difficult? Midline deviation by translation?
With okay,
And what do you think?
yeah, much very hard.
This is the facial midline. This is the facial midline. Midline is off to the other side by 2.5 millimeters, but occlusal plane tinting is in this way.
Yeah.
Is it? Number one, easy. Number two, not easy. Number three, terrible.
Terrible.
Absolutely terrible, 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 very, very, very terrible.
Yeah.
How come is it possible? It must have been associated with some underlying problem like trapped palate, very severe facial asymmetry, or deformity in the midface or something. It's not normal. It's not normal. All right?
Yeah.
Midline. Tiny little amount of midline deviation. What was his complaint? What was his complaint? Crowding. Minor crowding. Okay?
Yeah.
Minor crowding. What else do you see? Class 1. Slight class 2. Absolutely minor crowding. Absolutely. This is the model. Okay, my question. Check that. Once again, face. Okay, small arc. Okay. Slight protrusion, but it's not very worrisome. Crowding. Oh, tiny little amount of crowding. And model. So, here's my question. Is it simple or difficult?
Difficult.
Easy or complicated? Okay, one more time. Are you going to try only inside the alignment, or you want to try overall treatment? Overall.
Overall.
Overall. Okay, very well. You're very well advanced. Why? What makes you think like that? Why? First thing, you have an impression there's a midline deviation, but there's no tilting. There's no tilting. Even if it's a tiny little amount of midline deviation, 1 millimeter, only 1 millimeter, are you concerned? But I feel it's strange. What makes this kind of tiny little midline deviation without tilting? There must be some underlying problem. Okay, I got it. Okay, I got it. What is the problem? Asymmetric molar relationship. On the right, class 1. On the left, class 2. So, it has something to do with the etiology. Etiology. So, 1.5 millimeter deviation is absolutely related to the class 2 molar. Okay, let's not be complicated. Let's not be complicated. Let's just try inside the alignment. Let's make the patient happy. By reducing the treatment time, by reducing the amount of construction work. I'll try only 6 incisor alignment, 8 incisor alignment, and that's it. That'll take him around 6 months of time. That'll make him happy because it doesn't have to be 2 years treatment. What do you think? Okay, let's try for some reason. For some reason, he was demanding. Let's skip this part. He was demanding. Forget about it. Forget about it. He was demanding lingual treatment. So we started developing a line.
No.
In 2 or 3 months of time, what do you find? Midline is worse.
Yes.
Overback. What do you think?
decrease.
because the crowding over there outside is worse.
Yeah.
This is exactly what you're supposed to see if you don't give it a very good consideration. You understand? But we didn't panic. We didn't panic because we already inserted a mini screw here and there because
Yeah.
we started treatment based on this midline based analysis. Midline based analysis.
Okay.
Once again, don't you think it's strange why the molar relationship is asymmetric between right and left side? Class 1, class 2. You do this midline based diagnosis, and now you'll understand. In order for us to maintain the midline, our remedy construction plan for this particular case is to distalize the molar. Upper right, distalize the molar. Upper left, still we maintain the midline. In the lower arch, distalize the molar. On the right, no movement. On the left. This way, we can maintain the midline, upper midline. We can maintain the class 1 molar relationship. We can correct the class 2 molar relationship on the left. Is that correct?
Yes.
So based on the midline based diagnosis, you can try quadrant basis construction plan. You can make quadrant based construction plan. Do you understand?
No.
Do you think it's important? Very important. So based on this is our construction plan. This is our construction plan. Midline based diagnosis. Whether it's 2.5 millimeter, 2.2 millimeter, no, that's not important. What is really important is that we must distalize this segment. We must distalize this segment. By doing this kind of midline based diagnosis, what is our clinical decision? Okay, whether it's labial or lingual case, I have to insert a mini screw on this area to distalize this area. I have to insert a mini screw on this area to distalize that segment. All those plans must be made ahead of time, even before we start the treatment, even before we start leveling and alignment. So, even if something like this happened, we don't panic. We don't panic. We already have the safety device in the mouth. In the mouth. In the lingual case, many times we use a powerful or even the lingual mini screw in the mandible. I'm sorry, I'm the most crazy guy in the world you can ever imagine who places the mini screws on the lower lingual side. And I do it many times because I do a lot of lingual cases. Okay? But wait until next Friday. I'm going to explain the way how we do it.
Okay.
We have 3 mini screws. 1, 2, 3. If it were labial case, we would have tried mini screw 1, 2, or 3. Something like that. Okay? What matters is the way how you treatment plan each of the case. So we don't panic. We don't panic as the distalization goes by, and then you gradually strengthen the molar relationship. Molar relationship, and also the midline. Midline. You don't panic, okay? This is a kind of this is something missing from all the orthodontic literature, even from the contemporary orthodontics textbook. This is very technical and very important for our daily practice, but for some reason this is missing. This is missing. He's happy. Let's have a look at the superimposition. Couple millimeter distalized retraction of upper and lower incisors. That helps slight retraction of the lips. So he looks a little better, not very much, but a little better. Okay, this is a midline-based diagnosis. I'll ask you one question here. Let's try to diagnose this case. And I'll give you one question. If you find the etiology, I'll give you a prize. I'll give you a prize. 21-year lady with midline deviation. Spacing. Of course, she's got a small lateral incisor, which is one of the reasons why she has a spacing. But how come the midline deviation? How is it deviating? You know there's an asymmetric molar relationship, okay? That may be one of the etiologies. What about the midline according to facial midline? It's upper dental midline deviation to the left side, is that correct? Alright, so you diagnose upper dental midline compared to soft tissue midline. Why? Because of asymmetric molar relationship, maybe. But why asymmetric molar relationship? Last one. Why asymmetric molar relationship? Once again, why asymmetric molar relationship? Because of underlying asymmetry? Oh my God. That's it. Oh my God. She got the answer. What do you find? Rotation? Rotation, why? I strongly suspect the congenital missing of her upper left first premolar. Okay? Strongly suspect. That's what you said, right? My God. You are very well advanced. Unless there's a serious facial asymmetry or something like that, there must be some reason for the midline deviation. If it's a crowding, okay, the tooth germ was there, but just because it couldn't find the space to come out, then it will be tilted to either side, dorsal side, lingual side. At least the apex position will be okay. But this is something else. And I think about why. Serious class 3, and she's not supposed to class 3 skeletal pattern. No, she's class 1. Exactly class 1. What else do you find? So, class 3 molar relationship. Why? Strongly suspect congenital missing of her upper left first molar. So what you see in here must be second molar. This must be third molar. Yeah? That's my speculation. Maybe yes, maybe no. So what's the clinical implication for that? Because any congenital missing, if that was missing from the very, very first place, then they have been tilted to one side. No, not tilt. Migrated to one side from the very, very beginning, which means in order for us to correct the midline, it will take very serious bodily movement. So, what's the clinical meaning for that? All this speculation and thinking. What is the clinical implication? We need to estimate treatment time. Whether it will be 6 months or 2 years. So, here's my question. Is this going to be 6-month case or 2 years case? 6 months? 2 years. Yes, absolutely 2 years. Is that correct? So what are we supposed to do? Just because we diagnose this and that, we'll try tiny little amount of movement, but radical. The whole arch rotation to one side. Do you think we can do this thing with aligner, clear aligner, Invisalign?
No.
No, you cannot do that. So to a Invisalign seminar, the guys probably stand up and stay showing a lot of cases, and okay, they are very well done, very good, very well done. But some midline is their weakness, and midline is off to one side, even at the end of the treatment, and they say, have a look, this is well done. You're concerned about the midline? No, this is the exact desired treatment goal that we made from the first place. This is our desired goal. No, that's not desirable. I don't think that's desirable. You desire that midline, but that's not really desirable. I don't know. 2 millimeter midline deviation because of some underlying etiology would have to be solved in this way. 3 months. This is not easy because even if you extend the level arm, this is, I'm going to explain this later on. This is anterior-posterior long segment in the middle of protraction. The whole segment will be tortuous, will become tortuous. There will be bowing. So in the middle of the protraction, you may find some open bite, right? And you have to use maxillary elastics to flatten the occlusal plane at all times, and then restart the protraction and arch rotation, 8 months, 13. Now your midline is matched, close to top and bottom, this way, all right? Almost 2 years. Still there's a residual space. And I asked her whether she will have a laminate or some prosthetic work, and she says no. She's absolutely happy with this because the major concern for her was the midline deviation. Now it's matched. She's happy. Yeah, if it's your decision. But you're happy with the midline. Okay, I'm happy with change in the molar relationship. You're happy with that? I'm happy with this. So we both are happy.
Yeah.
At the end, very good. Without this kind of radical transition from class 3 to class 1, you are not able to correct the midline. Even if it was a tiny little amount of midline deviation, it was a very, very big commitment. Alright? So, she's happy? Before we have a little bit of break, I'm going to talk about a very interesting case. Very interesting case. Okay, I know there's a little bit gummy smile, but we are still in the midline assessment session. Straight profile. What else do you find? Especially the people in the middle row, you'll be able to recognize her asymmetry? Yes or no? Yes? Alright. Very well. Very well. Do you find any serious midline deviation of her jaw? Not really. Not really. Okay. Straight. Straight. Midline deviation. Rather serious. Rather serious. Okay? Class 3. This is a problem. This always is a problem. Always is a problem. What is that? Asymmetry. Facial asymmetry. It's terrible in my perspective. It's not terrible to the patient's side. Right? We want to try orthodontic surgery. She will definitely decline it. You understand? That's the problem. That's the problem. Asymmetry is not really forgiving. How can I say? Forgiving. Tiny little amount of asymmetry, midline deviation would demand us to commit orthodontic surgery. Us. Right? But do Do you think she will agree with the automatic surgery option? Yes or no? Of course not. Of course not. Not easy. What is the main problem in here? What is the main problem? Okay, she has underlying facial asymmetry. That's very true. We know that. Have a look at the PA view, posterior anterior cephalogram. Absolutely, this is a facial asymmetry. We know that. Okay? Facial asymmetry. Midline deviation. So, amount of midline, pattern of midline deviation, is it simple or difficult? Is it, okay, simple? Is it little complicated, or is it really terribly complicated? I think it's terrible.
Yeah.
I think it's terrible. So,
As always.
just because it's terrible, we'll definitely think about orthodontic surgery. Do you agree? Yes or no? 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 If no, what's your third option? Non-surgery? Non-surgery? Huh? Extraction. Do you think you can correct this with the extraction? With extraction? What about the midline? What about the midline? Midline looks like this. Not easy though. Not easy though. So we'll have to make a very modest and clever decision. We know how menton is deviated to our right side. Is that correct? Deviated to our right side. So first thing, we must relocate her menton. Relocate her lower jaw to her right side, left side. We have to move the jaw to her left side. You want to do that? You want to do that? Let's try. You can try without surgery. Ask her to move the jaw. Like this. That's what I do. That's what I do. I ask her to move your jaw so as to match the vertical line, make it coincident with the menton position. This is a simulation, clinical simulation. This is a clinical simulation. Do you like it better than this? This is asymmetry. This is relocated lower jaw. Which one do you like? Number one, number two? You don't like, you like nothing. You like nothing. If you still have to choose one out of these two, do you think this is desirable? Desirable? What makes you uncomfortable about this is the way how the nose is deviated. Nose is deviated. Just remember, when you have an asymmetry, it's not only about the lower jaw. The whole face is asymmetric. The whole face is asymmetric. Now you have to make a very clever and modest and reasonable decision. Reasonable decision. You have to determine the treatment midline. We know the nose ridge is tilted to our right side. Unless you correct this, if you correct the lower jaw in this way, now the nose ridge deviation becomes much more prominent because it's located in the middle of the face. Exactly in the middle of the face, that's like that. So if you have to choose between these two, I'll choose definitely this one. No relocation. No relocation. Because this looks nice and she thinks this is nice. Now, this is really important because based on this, if you commit an orthodontic surgery only for the sake of relocation of the lower jaw, let's say you relocated the lower jaw, spending $20,000 for the sake of orthodontic surgery, and in terms of facial control, this is the expected outcome. And what's the scenario? if she comes back from the oral and maxillofacial surgery department, spending some days in the hospital for the hospitalization, spending $20,000 for the orthodontic surgery, she will end up with crying in the orthodontic department. Why? Because she doesn't like the face, right? So no surgery, and our treatment will be like this. Even if the menton is deviated, just because nose ridge is also deviated to that side, I'll take this facial midline as our treatment midline in this case. Do you agree?
Okay.
So we'll try extraction and again asymmetric anchorage preparation using the. I'll try the same thing that I did in the previous case. We tried the whole arch rotation in the maxilla. I'm doing the same thing in the mandible to make the lower dental midline coincident with the upper dental midline without changing the jaw position. Okay? Okay? Maybe some of you might have done something like this maybe many times. But what I'm talking about is the way how you diagnose the case. It's about diagnosis. Okay? Diagnosis. Again, we didn't commit a orthodontic surgery. She's still asymmetric, but her nose ridge line is coincident with the menton position. This is an optical illusion. I'm not saying she's symmetric. She's never symmetric. She's asymmetric, so to speak. But the way she looks is okay. We didn't have to commit an orthodontic surgery. Even if her dentures looked very terrible. So this is it.
That's it.
So I introduced the way how we rotate the arch without major anteroposterior movement. On one side, let's get back. On one side, visualization. On the other side, it's missing from here. Protraction. This can be possible using multiple meniscus in a single arch. Okay, so this is the core idea, and you'll understand by now this kind of midline deviation is terrible case. It's terrible case. Do you understand? I will use the same rule for the molar correction tomorrow and day after tomorrow. Exactly the same way. Okay? You just shift the way how you see the object. Now we are seeing the object from the front. If you look at it from the side, the same rule will be applied for molar uprighting and molar retuning. Okay? The same thing, exactly the same thing. So, based on the midline, the amount of crowding, amount of molar dislocation, the pattern of extraction will be determined differently between right and left side. And this can be visualized. I think I can invite the laboratory technician to show you this digital step-by-step procedure to help your understanding in three-dimensional visualized treatment objectives. Okay? By using the midline, initial, simulated final, these two are superimposed. By simple superimposition, you'll be able to gain how much crowding you see on one side, how much on the other side. Very simply, okay?
Okay.
So, this is it. And we'll have a short break, about 15 minutes. Any questions so far?
Yeah.
How's the level of lecture? Is it okay?
It's okay.
Too simple? Too low?
No.
It's okay?
It's
Alright.
okay.
Have a little refresh. Okay. Question?